An enduring ethical dilemma in epidemiological research and mapping is the tension around protecting individual privacy, advancing social good, and in the global context, avoiding extraction while honoring reciprocity. Clinical case data, often including sensitive health and location information, are critical for understanding disease transmission and targeting interventions. Yet disclosing such information can stigmatize individuals and communities, especially where malaria is associated with poverty or marginalization. A reciprocity ethic requires that communities who contribute data have a meaningful voice in governance and see concrete benefits, such as improved services and removal of access barriers. When funders and implementers support data collection without parallel investment in local disease surveillance capacity, information systems, and workforce, the work can become extractive and reproduce historical power imbalances in malaria-prone regions. To protect privacy, researchers commonly offset patient addresses or aggregate case counts to broader geographic units, such as districts or provinces. While these practices reduce risks of re-identification, they introduce spatial inaccuracies that limit the precision of predictive models, which can in turn affect public health planning. For example, shifting a household location by even a few kilometers may distort estimates of local transmission hotspots, while aggregating to a provincial scale can obscure heterogeneity across villages. The ethical trade-off thus emerges as a function of spatial scale. The use of finer scale data supports more accurate interventions, but heightens privacy risks, whereas the use of coarser data protects individuals, but may blunt the effectiveness of disease control measures. In a global context, analysis should avoid extraction while leaning into reciprocity. In this setting, reciprocity means co-deciding with affected communities or their representatives how much spatial detail is released and pairing any shifts toward finer scale outputs with proportional safeguards and follow through, including targeted outreach where gaps are found, confidential feedback loops, and time-bound reviews that let communities adjust what is shared. Site suitability analysis for malaria prevention presents similar scalar questions with distinct ethical dimensions. Environmental suitability models that identify areas prone to transmission rely on spatial data about temperature, rainfall, elevation, land cover, and human settlement patterns. The resolution of these data sets fundamentally shape which locations are flagged as high risk and therefore targeted for interventions such as indoor residual spraying, bed net distribution, or community health worker deployment. Coarse resolution data may misclassify local microclimates where vectors thrive, leading to intervention gaps that perpetuate transmission in overlooked communities. While fine resolution data can pinpoint risks to the household level or neighborhood level, may trigger stigmatization, reduce property values, or discrimination in employment and services. These ethical challenges extend beyond technical accuracy into distributive justice and benefit sharing. When resources are limited, spatial precision should protect the most vulnerable while avoiding new harms, and communities labeled as high risk should participate in decisions and receive actual benefits that offset potential social costs. A people-first approach pairs any high-resolution targeting with community governance, clear consent pathways, and tangible returns, such as targeted services and interventions aligned with community priorities, and not just maps. The integration of case mapping and suitability analysis can compound ethical challenges by either reinforcing or mitigating scalar issues. When epidemiological case data and environmental suitability models operate at mismatched scales, their combination may produce misleading risk assessments, that misdirect interventions toward communities that appear high risk environmentally but lack actual transmission, or away from areas with ongoing cases but seemingly unsuitable conditions. This spatial mismatch can exacerbate inequities by systematically underserving populations whose disease patterns do not align with environmental predictions. For example, residents of informal urban settlements or areas with complex microclimates. When both approaches employ consistent scales and are co-governed with affected communities, they can provide mutual validation that strengthens targeting while distributing ethical burdens more equitably. Fine-scale integration can enable precise identification of hotspots while reducing false positives that might stigmatize environmentally suitable but disease-free areas, while coarse integration can protect privacy across datasets but may perpetuate intervention gaps. To avoid extraction, integration choices should be tied to community-approved data use terms, benefit sharing, capacity building for local surveillance teams, and service commitments that match the risks communities take by sharing data. These issues highlight the need for transparent discussions between researchers, public health officials, and affected communities about acceptable levels of privacy risk and analytic accuracy. Ethical practice lies not only in applying technical safeguards, but also in making explicit the consequences of privacy protection strategies for the quality of knowledge produced and the equity of malaria interventions delivered. Avoiding extraction while honoring reciprocity means pairing data collection with data sovereignty commitments and shared governance with real decision power. If data collection is not matched by investments in local surveillance capacity, the tools that protect and use the data, and the people who run them, the work remains extractive. And it must also deliver actual returns to communities that share their data. This approach upholds the obligation to society and to individuals by safeguarding privacy and dignity, delivering public health benefits, and ensuring that communities retain authority and share in the value created.